You know what I'm talking
Okay.
about?
I thought I was making it full screen for you guys.
Well, now it's just like these little windowed. There you go. Much better.
Much better. Okay, good.
Everyone
Last
agree?
time it was the opposite. There's no rhyme or reason to my computer, I'm telling you. Okay, we're going to go through the upper digestive system. Here we go. And we're going to blaze through. So everybody remembers what this is a picture of, yeah? Yell it out. What view is this? Look at your vertebral bodies.
Like a RAO or something.
That would be correct. Thank you very much, Brady.
Dang.
Okay, so your your digestive system, we're going to look at accessory glands in the alimentary canal. So your accessory glands are your salivary glands, your liver, your gallbladder, and your pancreas. Those are the glands that produce enzymes to help break down and digest food. Okay. The second part is the alimentary canal. Remember, it is a musculomembranous tube. It has the mouth, the pharynx, and the esophagus. Okay, the small intestine is what is doing the digestion portion, and the large intestine's job is to absorb water and eliminate waste. Okay. The components of your alimentary canal: the mouth, the pharynx, the esophagus, the stomach, the small and large intestines. Okay. Remember, the salivary glands help with mastication and breaking down with enzymes. Okay, what's mastication, you guys? Do you remember the terminology you need to know?
Chewing.
And deglutition. Deglutition, anybody?
Swallowing.
Yep, good. And then peristalsis, everybody remembers what peristalsis means, yes? Okay. Don't forget about your pharynx and the three different parts. There's the nasopharynx, okay, your oropharynx behind your tongue, and the laryngopharynx, okay? What's this small bone at the base of your tongue? Just trivia. Anybody? Yep, good. Okay. Okay, don't forget your esophagus has layers, 4 different layers. You've got a fibrous layer, muscular layer, a submucosal layer, and a mucosal layer. Remember, these layers go all the way through the digestive system, okay? So the walls of the small intestine are also composed of these same 4 layers: fibrous, muscular, submucosal, and mucosal. Okay, there's 2 indentations in the esophagus that you can see on barium films. Okay, the first one is the aortic arch, and the second main one is that left primary bronchus. Those are normal deviations of the esophagus and no cause for alarm. Okay, these are just showing how your diaphragm opens to let the esophagus through. Okay, this lies in the mid-sagittal plane. Oh, by the way, is my webcam still on, you guys? Can you see me?
Yeah, we got you.
I forgot to turn it off, Mark. Why didn't you remind me? We were going to try something, but never mind. Okay.
Well, can't you turn it off now?
No, I don't want to go backwards.
Oh.
We got too much to do. Okay, so your esophagus is going to originate at C6, which is upper thyroid cartilage, or Adam's apple in you guys. Okay, it lies anterior to your vertebral bodies, anterior to your spine, posterior to the trachea. Remember, the posterior surface of the trachea is flat. Okay, so the esophagus butts right up against there. It passes through the diaphragm at the level of about T10. Where it joins your stomach, right here, okay, is the esophagogastric junction, okay? The expanded portion at this terminal end right here is called the cardiac antrum. Do you guys remember that? I tested you on that a lot. Okay, here's the stomach. We had to label all of these parts, okay? So you've got your cardiac antrum, and remember, antrum, this A in antrum means area. So this is the cardiac antrum. This is an area here where the cardiac is lying behind here. This section right here where they join is called the cardia, and this angular area here is the cardiac notch. Okay, here's the fundus. You've got the body with the greater curvature here on the outside, the lesser curvature on the inside. Okay, this other notch here is called the angular notch. Then you have the pyloric antrum, another area here of the pylorus. Okay, then this little straight area before your duodenum is the pyloric canal. And then you have this muscular opening here, which is this pyloric sphincter. Okay, another view of this. Okay, here's the folds, the internal folds of the stomach called rugae. And you guys remember what these are for? What do the longitudinal folds do for us? Anybody?
Absorption.
Increases surface area.
Yes, that's correct. Okay, so not only does it allows for our expansion of our stomach, remember? So when it contracts, these folds come in and take up less space. And then when your stomach needs to expand because you've eaten a lot, these can go smooth and expands the surface of the stomach. Okay, the last portion is called the pyloric portion, and this straight part is the pyloric canal. Okay, this muscular part here is the pyloric sphincter, and that leads into this area here, which is the duodenal bulb. Okay, the lesser curvature here is the right border of your stomach. So remember how you're looking at your patient. This is their right side. The greater curvature here is the left border. And the cardiac angle is this sharp angle where the esophagus meets the stomach. These are all identifiers that you're going to need to know if they give you a picture of an upper GI. Okay, so the entrance and exit of the stomach is controlled by sphincters. Okay, the cardiac sphincter controls the opening into the stomach. The pyloric sphincter controls the opening exiting the stomach. Okay, once again, body habitus matters with our imaging for upper GIs. So our hypersthenic here, your stomach is going to be pretty much horizontal in your patient. These are the broad, massive, stocky people. Okay, your average sthenic patient should have half and half, some vertical and some horizontal stomach. Then you've got a hyposthenic patient, which is more slender. It's going to have more of a vertical stomach. Then you have asthenic, which is very slender, frail, very vertical stomach and lower into the lower abdomen, pelvic area. Okay. Now I have a question for you. If you have a horizontal stomach versus vertical, and you need to see the structures of the stomach offset from this horizontal area, do you need to oblique your patient very little to see those other structures, or a lot if their stomach's horizontal? Anybody?
A lot.
A lot. Good. So remember in our stomach imaging, we had a big range when we had to do like our LPO for the upper GI is 40 to 70, I believe. And so for these hypersthenic patients, you're going to have to angle more towards 70 than you would for these little guys over here. They'd be on the lesser angle. Okay, this is a good slide for you guys to know where your orientation on your body habituses are. Okay, so for our average patient, we have a J-shaped stomach, half vertical, half horizontal, and your bulb should be about L1 and 2. Okay, everybody else is going to be above that if they're hyper, below that if they're hypo. Okay, here's another view of that. Okay, L1 and 2, right here is your average. So if you learn that, remember this anatomy here for your average, then you can kind of guess if they talk about hyper or hypoasthenic. Okay, the function of the stomach is a storage area for food. It secretes your acid and your enzymes to break down your food. Okay, it mechanically breaks down the food by churning and peristalsis. There's two mechanisms here. The kind that it makes is chemically and mechanically altered food. This is what is leaving the stomach, moving into the small intestine. Okay. It is pulpy acidic fluid, which passes from stomach to small intestine. Okay, so what's the most superior portion of the stomach?
The fundus.
Good. Okay, these are located within the stomach walls and are longitudinal folds. Everybody got that, I hope. Rugae. The portion of the stomach that is located on the left side of your patient. What's that called?
Greater curvature.
Good, good. Okay, the right border of the stomach is called the...
Lesser.
Okay, good. Most superior portion of the esophagus.
Mouth.
Laryngopharynx.
Okay, so remember we've got our pharynx. Okay, so we have our nasopharynx, we have our oropharynx, and that's still behind the throat. And then your laryngopharynx comes in, and that starts your muscular tube. Okay, your that tube with the 4 different layers start there. Okay, organs for swallowing. Anybody?
A.
Organs. How about salivary glands? Anybody? Accessory organs? Do they help? Okay, we're gonna move on.
Salivary glands.
They break down. Okay, they break down. And then the muscular is the contraction part for swallowing. Okay, the muscular tube wall of the alimentary canal is composed of 4 layers. And what are they again? We know cardiac is not the answer. So those 2 are gone. So it's going to be A or C. Fibrous,
C.
muscular, submucosal, and mucosal is correct. You're just going to have to remember that, you guys. We're going to blaze through the technical part. Don't forget peristalsis is contraction waves for which the digestive tube propels the contents out toward the rectum. There are 3 to 4 waves per minute that occur in a stomach that's full of food. The average emptying time for a stomach is 2 to 3 hours, and the transit time to the ileocecal valve is 2 to 3 hours. Okay, so once it empties the stomach, it's another 2 to 3 hours to that valve. Okay, bariate sulfate's the most common contrast for the alimentary canal. We can also use gastrographin or water-soluble iodinated contrast. But what happens when we switch from barium sulfate to water-soluble? Does it slow the process of moving the contents toward the rectum, or does it speed it up? Anybody?
Water solubles faster.
That is correct. Okay. So it moves through the GI tract much quicker than barium. This will clear the stomach in 1 to 2 hours. So if you have a patient and you're ruling out a perforated bowel, you would use water-soluble contrast in case they have to go to surgery, but you're going to need to remember this timing issue changes. Okay. Okay, so let's get into upper GIs. It's going to be a single or a double contrast upper. And what's our 2 mediums for a double contrast? I'm going to blaze through this stuff. What's our other contrast agent in a double?
Air.
Air, good, okay. So the biggest challenge with any type of fluoro is to eliminate motion, and peristalsis is greatest in the stomach and the duodenum. So if you're doing an upper GI or an esophagram, you need to remember that your exposure time must be increased. It must be quick, okay? So usually we want 0.1 second or less, okay? So that we don't have a blurry image due to peristalsis. Okay, don't forget when we were practicing our esophagograms, if we are giving the patient that cup next to their face and they're swallowing while we're getting our rotor fired up, when we take the picture at the end of that swallow, when you swallow, you cannot breathe. So therefore, you don't have to tell them to hold their breath or anything. Everything stops while we're swallowing. So if we do it at the end of swallowing, we are good to go, okay? So swallowing inhibits respiration for several seconds. Okay, so for normal peristaltic activity, so now we're talking about the stomach, we want our exposure time no longer than 0.2 seconds and never longer than a half a second, okay? Half a second. We're gonna make all of these exposures at the end of expiration. Thank you, Mark. Bye, Mark. Okay, so peristalsis is affected by body habitus, use of narcotic pain meds, and body position, which is true. Anybody? They're all true, okay? So your body habitus, your use of narcotic pain meds, that just stops peristalsis, okay? That's why a lot of people get constipated when they're on narcotic pain meds. Your body position, upright versus recumbent, okay? Iodinated contrast agents move through the stomach slower. That is false. Okay, so let's get into our imaging. Okay, we use positive or radio opaque contrast. Negative is air, like Mariah was saying, okay? Positive contrast absorbs more x-rays. That's why it's going to appear white on your film. And this is the composition, barium sulfate. Okay, this is just different types of contrast that are out there. Different brands are more dense than others based on the concentration. You got to remember that you have to shake this stuff up so that it doesn't separate and it won't be too dense or too diluted when you give it to the patient. Okay, there's different types, thick and thin. And if we needed water soluble, we would use that for a perforated viscous or any type of pre-surgery. We do not want them going to surgery with barium because if they ruptured or any kind of nick in the bowel and barium gets into your peritoneal space, it can cause infection, etc. A contraindication to this, as with anything, is a hypersensitivity or allergy to it. Okay, so the only contrast we're going to use for the single, of course, is barium. The other type of contrast for the double is going to be either carbon dioxide, the little tablets that we can give them, or granules, or room air. And we don't necessarily use room air. That's not preferred. Okay, so with this double contrast, the reason we like it is we use a thicker barium. It helps coat the inside lining so that you can see the folds well once you have given your patient the air. Okay, so that thick barium can coat inside and then the air can delineate those folds. Okay, this is just your fluoro equipment. You guys know all that already. Okay, we're going to skip through filters. This is your radiation pattern from a fluoro tower. I think you guys just went in over all your fluoro stuff, so you know how to be protected. Okay, so is this upper GI here? We're going to go through MPO air for 8 hours prior to the study. We do not want any gum chewing. We don't want any smoking. Okay, because that causes the saliva and for you to swallow a lot and it speeds digestion along. Okay, your routine. So we're going to start with your esophagram. Okay, so your patient's NPO. You're going to have a routine protocol of an RAO, and that's going to be oblique 35 to 40 degrees. You'll do a lateral and you'll do an AP or a PA, whatever your doctor prefers, one of those views. Okay. For your RAO, your patient is going, we practice it supine. Okay. We also practice prone. The head is going to be turned to the side to facilitate the drinking. The IR, is placed at the level of the mouth. Okay, that's pretty much all you need to know, because once it's placed at the level of the mouth, you know you're going to have the top of the esophagus. Okay, you're going to be using a 14 by 17 long cassette lengthwise. However, you can collimate down to 5 by 14 inches. An average esophagus is only 10 inches long. So as long as you have the top of that IR at your level of your mouth, and then you collimate to 14 inches long, you are going to get more than enough. Okay, you're going to center your central ray to the middle of your IR, which is usually about T5 or 6. Okay, and remember, we're going to have them drinking during this procedure. So we want to have a cup of barium with a straw for them. We're going to have them take a mouthful and swallow it, take another mouthful as you're stepping back to the control area, get the rotor going, have them swallow, and then take your exposure as soon as that swallow is completed. This is what that should look like. At a 40-degree angle, 35 to 40-degree angle, your esophagus should be demonstrated between the spine and the heart, right there in the middle. You should see it in its entirety if they've already taken a drink of the barium and they're on their second drink full there. Okay, and you see your normal indentations. You should have your aortic notch here and your left pulmonary bronchus. Okay, the next one you can do is your right lateral. Okay, same thing applies. The IR should be, this is way too high, but the IR should be starting at the patient's mouth. Okay, you can collimate the same, a 5 by 14. Okay, and you're going to be doing a true lateral. So remember where your esophagus is when you're going into your lateral position. You do not want your central ray centered on your spine. You're going to have it anterior to your spine, so your mid-coronal plane. Okay, and this is your lateral here. So your esophagus should be lying anterior to your spine with no rotation. So a true lateral. Make sure your arms are up out of the way. Okay, and then your last one's going to be a PA or an AP, depending on what the doctor did for you. Okay, it's still placed at the top of the level of the mouth. Central ray will be centered to that, which corresponds with T5, 6. And you're going to collimate in 5 by 14. And this should be a picture of this, your AP esophagus. Now this has pathology for sure. This is dilated big time. But you get the gist. Okay, so for the upper GI series, NPO for 8 hours prior to the examination, you want the patient's stomach to be empty. You would like them to be prepped in the entire bowel, but that is not necessary for this exam. Okay, food is withheld before the following day after the evening meal if you're going to do a small bowel follow through as well. Okay, don't let them chew gum or smoke cigarettes because of the gastric secretions it stimulates. Okay, there's such a thing as single and double contrast upper GIs. Okay, we don't normally see biphasic exams anymore, but you guys might. So you'd have 2 different types of barium ready if that's the case in your site. Usually begins with the patient upright on the fluoro table. Okay, so this is our protocol that we went through here at Gernick, and most of your site places had one or all of these. Okay, so the RAO, just remember that too, nowadays with our upper GIs fluoro studies, a lot of doctors are taking spot films and no longer thinking overheads could be necessary. So make sure you just follow your protocol. but that's something that is for radiation protection purposes. Okay, so we did an RAO for the upper GI, we did a PA, a right lateral, an LPO, and an AP. And what we did was turned them in one direction. So depending on how the radiologist left your patient, we started with that and moved them in the same direction at a quarter turn. And this is a good picture of, here's your fundus full of air, greater curvature and lesser curvature. Here's a little bit of barium residual in the esophagus, so you can see where that joins. Here's the straight part of the pyloric area, so there's your canal. Here's your bulb outside of the sphincter. So once you know where the sphincter is, you can see the bulb. Okay, here's your descending duodenum. Okay, and this is the rest of your small bowel here, your jejunum. Okay, so the midline of the IR is going to be aligned with your sagittal plane. This is for our RAO, okay? It passes midway between the vertebral column and the lateral border of the elevated side. Okay, so if we're in an RAO, we know the stomach is on the left side of the body. We positioned our patient at a 40 to 7 degree angle just to make sure that we can see what we're supposed to see. We want to see the pyloric canal and the duodenum here. Okay, so what we are looking for is find your midline where your spine is in your patient, and then the lateral border of their body, and you're going to split the difference. Okay, you're going to put your central ray in the middle there, and hopefully you get all of your stomach. Okay, central ray is perpendicular to the center of the IR, and it's a 10 by 12. Okay, all of these exposures are going to be on suspended expiration. Okay, your central ray is going to be centered at L1. Remember how we found L1? So the top of the crest, and then we went up 2 to 3 fingers above that. Okay, that should be the center of your field of view. Okay, this is going to demonstrate the entire stomach, your duodenum. Okay, your body and the pylorus should be filled with barium. Okay, your duodenal bulb and your C loop of your duodenum should be in profile. Now this is hard to see. It all depends on body habitus and patient angles and things like that, but this is ideal if you can see that. Okay, there's air in the fundus here and barium in the body. Okay, so remember barium is heavier than air. Okay, so the body of the stomach is inferior to the fundus, to the air. So they are in the prone position. They're in an RAO position. Okay, then the PA. Okay, they can be recumbent or upright for all of these, you guys, on the fluoro table. Any questions so far? Okay, we're almost done with this slideshow. So I'm just going, if I'm going fast, slow me down if you need me to. Okay, but this should all be review. Okay, so your midline of your grid should be to the sagittal plane. It's going to pass halfway between the vertebral column, the spine, and the left lateral border of your patient. Okay, the center of the IR should be 1 to 2 inches above the lower rib margin, or at L1, 2. I find it by the top of the crest and putting fingers up there. Okay, upright requires the IR to be centered 3 to 6 inches lower. That's just a note to know that people's stomach drop down when they're upright. Okay, so you're going to lower your center point. Okay, the central ray is perpendicular, no angle. We're still using a 10 by 12, and everything is made at the end of suspended expiration. Okay, expiration. And here's a PA. And this is your picture of a PA. Okay, so you should see your entire stomach, your entire duodenum, the body, and the pylorus, barium filled, air again in the fundus because we're still PA. Okay. Okay, Here's your lateral. We're going to do a right lateral. Okay, the recumbent right lateral is going to demonstrate the right retrogastric space, the duodenal loop, and the duodenal jejunal junction. A left lateral will demonstrate the left retrogastric space. Okay, retro meaning behind. Okay, we did right lateral positioning. So your central ray is going to pass midway between the mid-coronal plane and the anterior surface of your patient. So remember where your stomach lies. You don't want to put it on the mid-coronal plane. We don't care about the spine. The stomach's not laying on the spine. Okay, so we want mid-coronal plane forward. We want all of this area where the stomach can be laying. Okay, your central ray is still L1-2. And it'll be lower if they are upright. Make sure that they are in a true lateral, so the shoulders and the hips are in the same plane. Okay, your central ray is perpendicular with a no angle, and we're using 10/12s. Again, suspended expiration. Okay, here is positioning for a true lateral. Okay, and here's your picture. So you see your spine, this is cut off quite a bit, but you see in front of your spine, you have good centering here. This is about the center, I'd say. So I would go a little bit more forward, okay? But this is showing you the entire stomach, okay? And here's your duodenum, okay? Some of your jejunum. Here's your retrogastric space, so the space behind the stomach. It shows your vertebral bodies are in a true lateral, no rotation. Okay, and now we're in our LPO position. So we've done our RAO, we've done our PA, we've done our right lateral. Now we're coming back around the other way. So we're going to do an LPO. We're going to line the midline of the IR with the sagittal plane. And we're going to go midway between our spine and the left lateral border. So the same kind of centering because the stomach is on the left side of the patient, okay? You're going to center it to a point that's midway between the xiphoid process and the lower rib margin, okay? Your rotation is going to be 30 to 60 degrees. We took an average of that and made it 45 for everybody, but you guys know with your hypersthenic patients, you might need to be more than that, okay? And less with your asthenic. Okay, it's going to be perpendicular, no angle, 10/12 again. Okay, here's our centering. Now this, I think, should be moved over. This is the left side of your patient, okay? So this should be moved over to here, okay? Just saying. Central ray is going to be centered to 1, L1. And this is a nice picture. You can tell it is obliqued by looking at your vertebral body. So you're in oblique, okay? This is the left lateral margin. Here is your spine, so we should be centered here. And it shows barium in the fundus now. And remember the fundus, when we are lying on our back, the fundus is the most posterior portion, okay, inferior. And then the body is more anterior. So now we have air in the body, and you should be able to see the entire stomach and the duodenum again. Okay, that's a good picture. Okay, and then we just roll them straight into supine AP position. Remember, if you are looking for a hiatal hernia, you're going to put them in Trendelenburg because you want that air to go into the most top portion of their stomach that is protruding through the diaphragm. You're also going to not use a 10/12 anymore. You're going to put a 14/17 in there and open it up a bit because you don't want to miss part of that hernia. Okay, 10/12 IR, and it's going to be midway between the xiphoid and lower rib margin, perpendicular central ray, no angle. 10/12 for routine AP stomachs, suspended expiration. Okay, here's a picture of that. This looks a little, well, for her body habitus, this looks good, but this looks a little large to me. This is more than a 10/12. I'm just saying. Central rays at L1, make sure there's no rotation. They're nice and flat. Okay, and then you're going to see, now they're This looks, well, maybe they are straight and they just have a little bit of scoliosis. Okay, so your spine should have no rotation. You should see the entire stomach and the duodenum. Okay, fundus is going to have barium because it is more posterior. Okay, barium falls, it's heavy. The air rises to the top, so this body of the stomach is more anterior. You see the folds nicely, so you've got a double contrast upper GI here. Okay, PA oblique projection. So this is your RAO of your esophagus. Requires the patient to be what?
B.
Yes, B. Which position may be used to demonstrate a hiatal hernia? C. Trendelenburg. Okay, the stomach orientation. These are just a few slides to show you how stomach positions can change. Okay, so I want you to notice here in this lateral view how the stomach, the fundus of the stomach is closer to the spine, more posterior than the body portion here. This is more anterior. Okay, and this is your air barium distribution. So when you have a full stomach full of barium and you're using a double contrast, so your air is black and your barium falls to the heaviest point. So when they're supine, the fundus is the lowest point, the body is risen up, more anterior. Opposite is true for prone, okay? And then erect air goes to the top. Okay, so which one here was taken prone? Any guesses? Which one is prone? This one or B over here?
What?
Is it B?
B, yes, good.
B.
The barium falls to the lowest point, okay? Lowest point. It says supine, that's not correct. What position is this, you guys? Air is in the fundus. Okay, look at the spine. Look at the pelvis.
That's a supine.
Does air go to the fundus when you are supine?
Prone.
Oh,
Prone.
prone.
Prone, okay. So remember where the fundus is situated is closest to the spine. The fundus is closer to the spine than the body of the stomach. Okie dokie. Okay, that's it for this slideshow. I think we're ready for a break. I'll see you guys back here at 10 and we'll start with our small bowel.
Therese,
Yes.
do we have Memorial Day off from school?
Yes, it's a school holiday.
Okay, I figured. I just wasn't sure with all this online.
No, it's
Yeah.
one of your school holidays, so you won't have to do any 8 hours of work for that day.
Cool. Okay, thank you.
You're welcome.
Therese, I have a question.
Yes.
So air goes to the fundus when you're prone. And then
No.
what did you say about barium? What does barium do when you're
Okay, so when you are prone, so if you are prone, okay, your spine is closer to its anterior, right? Supposedly, if you're thinking
Yeah.
about it's more superior, say that way. So if you're laying flat, your spine is up top,
Mhm.
right? Your navel is lower. The fundus of your stomach is closer to the spine. So when you're prone and you have air in your stomach, that air is going to rise.
Okay.
Do you get it?
I get it for the air portion, but what did you say about barium? What does barium do?
So barium falls because it's heavy. So the
Okay.
air rises to the uppermost top part, the superior top, and the barium falls. So if we're prone, the air is going to be in the fundus because it's rising to
Okay.
the top part,
Okay.
and the barium is going to be in the body of
Okay.
the stomach.
All right, I get it.
Okay, and then opposite if you switch yourself around. So laying on your stomach, your fundus is closest to your spine. So it's going to fill with that heavy barium, and the body is now up here from the stomach, and that's going to fill with air.
Got it. Thanks.
Okay, it's confusing, but try to just memorize one way, know for sure it's correct, and then you'll figure out the other one. Okay?
Okay. Thank you.
You bet. Okay, I'm going to take a break, and I will be back.
The bacon.
Okay, very good. All right, so moving on to the small intestine. Okay, it extends from the pyloric sphincter to the ileocecal valve. It is in 3 portions. This first portion is, of course, the duodenum. Okay, second portion is the jejunum, and that is the one with the feathery appearance. Okay, and then the last portion is the ileum, and you can remember that's the last portion because this is the ileocecal valve down here where it meets the large intestine. Okay, the first portion, the duodenum, is 8 to 10 inches long. It is C-shaped. Okay, so your first region you have is your superior portion, then you have your descending portion, then your horizontal portion, then your ascending portion. Okay, remember this ascending portion will have a sharp turn. This is the junction where it meets the jejunum, where it starts getting that feathery appearance. The reason it has a sharp turn is it's held up by a ligament, the ligament of Treitz. Okay, that's a suspensory ligament. You might need to remember that. Okay. Okay, this is shot up close of the internal part of the duodenum, and this is aids in the digestion and absorption of food. Okay, and these little finger-like projections are the villi. Okay, that lines your duodenum. Remember, there's 4 different layers, okay? Same layers that the esophagus has. Okay, it is the shortest and widest, this first portion. It's in the shape of a C. It's called the romance of the abdomen because it's hugging the pancreas, okay? Hugging the pancreas. The duodenum is retroperitoneal. So what other organs were retro? You guys remember?
Kidneys.
Kidneys and what else? Hint, the duodenum hugs it.
Pancreas.
That's right. Okay, so all of these are retroperitoneal. And then when it goes into the jejunum, that's where it's coming back into the peritoneum. Okay. Okay, so here's your quadrant sections. We all know where everything is in our quadrants, right? So our duodenum is going to be in the upper quadrants. Some people, it's going to be entirely in the right. Some people, it'll share right and left, okay? The jejunum is going to be on your left side mainly, okay? Your ileum can be in all 3 of these sections, mainly in the lower, okay? But all 3 here. Okay, the ileocecal valve, though, easy to remember, it's always going to be in the right lower quadrant, next to the appendix. If you have an appendix, next to the ascending of the large bowel. Okay, and this is a good radiograph of that. Okay, this looks like a small bowel follow through. What orientation is this? Is this supine or prone, you guys? Look at the pelvis. Anybody?
Prone.
Prone. Very good. Very good. Yay. Okay. So we have a right upper, left upper, right lower, left lower. Okay. So where's our appendix going to be? Where's our ileocecal valve going to be?
Right lower quadrant.
Very good. So that's where we're going to look for our ileocecal valve. That's where we're going to look. And it looks like this right here starts the large intestine. You can see some haustra coming here. Okay, so most likely this is the cecum. So if this patient still has an appendix, it's going to be coming out of this area somewhere around here. So the ileocecal valves is going to be around here somewhere. Okay, so this radiograph is showing your duodenum. Okay, your duodenum, your jejunum, which has that feathery-like appearance, and this is 2/5 of your small bowel. And then your ileum, which is the lower part, is going to be the other 3/5. Okay, remember this is just a short 10 inches. Okay, something to remember when we're taking pictures of this area, peristalsis. Okay, these are those contractive waves that propel everything towards the rectum. And the average transit time to the ileocecal valve after it leaves the stomach is 2 to 3 hours. That's average time. Okay, so our challenge is to eliminate motion from peristalsis. Okay, it is greatest in the stomach and duodenum, and it slows as it goes to the distal part of the GI tract. So it's fastest in the stomach, the esophagus and the stomach and the duodenum, and then it starts slowing down once it enters the bowel. Okay, it's affected by body habitus, pathology, use of narcotic pain meds, body position, and respiration. Okay, remember, if we're swallowing, we're not breathing, and hopefully our peristalsis is slowed. Okay, so normal peristaltic activity in the small bowel should have us be doing exposure times no longer than 0.2 seconds, okay? Never longer than a half a second. And if it's somebody that is moving really, really quickly, they're not absorbing any nutrients because everything just flies through their bowel, then you might need to speed it up like an esophagus and do 0.1 second, okay? All the exposures are going to be made at the end of expiration. Okay, here's your contrast media once again. Okay, same kind of thing. Make sure you're reading labels so that it is for the exam that you're looking at. You don't want to give your patient the wrong type of contrast with your doctor there, and your study be not, because they can't see through the barium or it's too dilute or any of those things. So make sure that you're using the right type of barium for your exam. Okay, barium and other contrast can be administered one of 3 ways. Usually we see it orally, but if you're in the hospital setting, you can see it through reflux filling, okay, BEs for example, or a direct injection through a tube, okay, placed into the small bowel or the stomach. And remember, these tubes, depending on where they're placed, have a different type of name, okay? And when we do enteroclysis protocols in the outpatient setting, we're doing oral barium and then taking pictures in the CT scanner or the MRI scanner. Okay, patient prep for a small intestine examination, which is usually a small bowel follow-through, is a soft or low residual diet. That means no fiber, okay? A lot of liquids for 2 days before the study. Food and fluid are withheld after the evening meal on the day before. They can take small sips of water, okay, but no other fluids. Breakfast is withheld on the day, so no food or fluid after the evening before. This goes without saying then. Okay, some patients need to do a cleansing enema so that the colon is not filled with residual fecal matter. Okay, the main takeaway for small bowel follow-throughs are it is a timed study. It's a small bowel series because there's several identical images that are produced at timed intervals. Each image must be identified with a time marker indicating how much time has gone by since ingestion of barium. Okay, images are obtained with the patient in either the supine or the prone position based on your radiologist's preference. However, once you start taking pictures, you don't flip-flap back and forth. You keep doing the same type of imaging so that they are identical images, but different times. Okay, this is an excellent image of the feathery appearance of the jejunum versus the ileum. okay? And this should be right here, should be where our junction is. This is our cecum, it looks like. And you can see this is large bowel by the haustra. Okay, so the supine is used to take advantage of the superior and the lateral shift of the stomach. This improves visualization of the duodenum and the jejunum, okay? It prevents the compression of overlapping loops of intestine. So if the patient is laying on their back and they are supine, there's no pressure on that small bowel, on those loops of intestine, okay? And so they have a little more room to shift, okay? So you can see the upper part of that a little better. We use prone to compress the abdomen. It increases the image quality because anything closest to the IR looks better, okay? But it's also compressing those overlapping loops of bowel. So it's all radiologist preference depending on what they're trying to see. Okay, the first image is usually taken 15 minutes after we ingest the barium, okay? You're going to take a scout actually before you ingest any barium. So that's your real first image. But you take a scout, then they start drinking, and then you take timed pictures after that. Now, if it's before the first half hour, does anybody remember what we need to do for our images? Anybody? So for a small bowel follow through, if we're taking pictures before 30 minutes, they've drank in their barium and it's before the 30-minute mark, we're going to center a little higher because of why? Anybody? Because we want to see the stomach where the duodenum enters the stomach, okay? And that's high. Okay, after the 30-minute mark, the barium has left the stomach, the duodenum, okay, and it's starting to enter into our bowel, okay, and then we can center normally, okay. This is a couple images of spot films that the doctor is taking. This has got some pathology here. This looks like Crohn's because it's got that cobblestone appearance, okay. The examination will be completed when the barium is seen in the cecum, okay, of the large intestine. This is normally 2 hours after the patient has first ingested the barium. Now, we had mentioned in our other slideshow that the stomach takes 2 to 3 hours to expel the contents. That's when it needs to be digested. Okay, so those are whole fibrous foods. They need to be digested and broken down. The stomach can take 2 to 3 hours to expel those contents and make chyme. Okay, but with barium, we're not digesting the barium. It's inert. It goes right through the system. So that's why we can start taking pictures 15 minutes after ingestion. Okay, so now we're going to look at some pictures, and there's some pathology evident in these pictures as well. So this shows enteritis or gastroenteritis, which is an inflammation of the intestine, okay? Usually an inflammation of the small intestine. This is a little one. They get this a lot. Okay, this is Michael's diverticulum right here, and that's just an outpatching, okay, outpouching or a bulge in the lower part of the small intestine. Okay, the bulge is congenital, so meaning it's present at birth. It's a leftover of the umbilical cord. It's called Michael's diverticulum. Most common congenital defect in the gastrointestinal tract. Okay, this is showing a cancer or a tumor, neoplasm, new growth. Okay, this is showing a colon cancer, which has what's called a napkin ring or an apple core sign. So the tumor is growing out here, and that's a radiolucent body, but the barium is going through the lumen that's left of the bowel and giving you this apple core sign. Okay, this is a malabsorption syndrome, and there's a lot of the syndromes out there where you do not absorb the nutrients that you need. Okay, nutrients that the small intestine often has trouble absorbing can be proteins, carbohydrates, fats, things like that. Okay, and there's usually pathology in the lining of the small bowel that prevents the absorption of those molecules. Okay, this is ileus, and ileus is just where your bowel does no peristalsis, and it is pretty much frozen, for lack of a better word. Okay, and it can be caused by mechanical issues, or there's paralytic ileus that can be caused by drugs and disease. Okay, this has got a lot of, so the air is just filling up this bowel. The bowel is not expelling any of the contents or getting any nutrients from anything coming through. And this is very painful. Okay, this is that cobblestone appearance here in the small bowel. This is Crohn's disease. Okay. Giardiasis. Okay, this is an infection of your small bowel by a microscopic parasite. And how they know that this parasite is infected, besides running other lab tests, is this dilated intestine with thick circular folds. Okay, so this is small bowel and all of these thick circular folds. This is a paralytic infection. Okay, parasites. Okay, ileus of the small bowel again. So this is just paralysis of the small bowel. Shows the extended loops. Okay, and this here, do you guys remember what this is? I think I showed you guys this before. This is a roundworm infection. This is common in some of the villages in Asia that mainly eat fish, raw fish, that can be infected with parasites. Okay, PA or AP. So looking at this pelvis here, this looks like an AP, okay? And so the loops are not compressed, and they should be able to see the duodenum here in the upper part of your jejunum fairly easily, which we do. Okay, so you've got your stomach here, your duodenum, your jejunum, feathery appearance, your ileum. And then over here, you can see your ileocecal valve, and this is where your ileus and your large intestine meet. And then this is your cecum, and up to the ascending colon. Same prep, okay? Okay, so for our centering, for the 30-minute interval, you're going to center at the level of L2, because anything up or before 30 minutes or up, we want to center above. For all the delayed images, however, we're going to center at the iliac crest to get the rest of the bowel. So anything before the 30-minute mark, we're going to center at the level of L2, and delayed images after 30 minutes are going to be at the crests. Okay, no angle on your central ray, it's perpendicular. We're using a 14/17. All of these exposures are going to be made at the end of expiration, just like for the upper digestive systems. Okay, and remember, you're going to mark with time. That is the whole point of this study. So mark your timed images. And if you're starting with prone, because that's your site preference, you're going to do all of your images prone. Okay, and this is a good one. This is prone. Okay, it looks like it's not flipped like it should be, because this looks like you're ascending here. Unless it's just dilated small bowel, it could be. Oh, there's your cecum. Stomach, duodenum, here's your jejunum. Okay, looks like here is your ileum. Okay, here's some different procedures. Your upper GI can be linked to a small bowel follow-through. You could just do a small bowel follow-through alone. You can do an enterocolysis, which would be with CT or MRI usually these days, or you can do intubation methods. Okay, contraindications for barium sulfate if they're going to surgery, if you know that they have a perforated bowel. Okay. If there is a large intestine obstruction, you also don't want to give barium sulfate. Okay. Contraindications to gastrografin or water-soluble contrast can be younger patients, anybody that's dehydrated, because these iodinated contrasts do dehydrate you even more, or if you're allergic to iodine. Okay. If you're doing a combination study, you're going to do the routine upper GI first, okay? But you're going to still time everything. You're going to note all of those times, okay? Then after they've finished the upper GI, you're going to start your 30-minute interval radiographs, okay? And then if your patient is ready, it's hit the ileocecal valve, then you're going to take them into the fluoro room for the spots with the radiologist, if that's your protocol. This is just showing what's called a compression cone on your fluoro unit. And that is in place of the inflatable ball that they use with the radiologist using his hand under there. This is way he can use the actual fluoro tube, okay, fluoro tower, to compress that area to get a better image. Okay, so for a small bowel series only, they usually give 16 ounces of barium. We usually give 2 cups of that or 2 bottles of that, okay? And we have them ingest that, and then we start with our radiographs. So the intubation method here is using a catheter. These should have already come down to the floor with the catheter in place, okay? You would never inject anything to a catheter or a line. That's the radiologist's job. It would be a thin mixture. Okay, and then you're just going to take pictures as the radiologist orders them, because these patients are usually pretty sick. Okay, this is a CT enterocolitis. Yeah. Okay, average transit time of the contrast agent to the ileocecal valve of the small intestine is 2 to 3 hours. The exposure time for small bowel projections to avoid imaging motion should be between what and what for normal peristalsis? The answer is D. No, that is not correct. The answer is B, 0.2, no later than a half a second. And that's it for that slideshow. Any questions on small bowel, you guys? Small bowel imaging. Any questions on that? Okay, so it is 10:28. We're going to go right into the large intestine. Okay, are you guys good? And then we can maybe end early if we get through everything. All righty. Okay, large intestine anatomy. Okay, so the function of the large bowel is reabsorption of fluid and elimination of waste products. So transportation and elimination of the rest of the products that we can't do anything with, okay? The large bowel begins at the junction of the small intestine and ends at the anus, okay? It forms an arch around the loops of small intestine. So here's your arch it's forming, okay? And it has 4 main parts, okay? It's got a cecum, a colon, a rectum, okay, and the anal canal. Okay, the large intestine is approximately 5 feet long. It consists of a series of pouches along the large intestine. These are called haustra. And the teni coli are muscular bands that form the haustra. The cecum is a pouch-like portion below the junction of the ileum, the terminal ileum, just meaning the end of the ileum, and the colon. And this is the valve where they meet, okay? The variform appendix is attached to the posterior medial side of the cecum. So posterior behind and medial side of the cecum is where the appendix will hang off, okay? So we have our cecum is the first part of the colon. Then we have the colon. Then we have the rectum and then the anus. Okay, so the anatomy is, here is some labeling that you guys need to know. Okay, cecum, ileocecal valve, ascending. Here's your right colic flexure, also known as what? Any guesses? What sits up top here? Anybody?
Hepatic flexure.
Hepatic.
Hepatic, very good. Okay, transverse colon. Then we have our left colic flexure. That's also known as the splenic because the spleen sits right here. Okay, then the descending. Here's your teni coli. Okay, your haustra. Your sigmoid colon is the S-shaped part of the lower colon. Then we have the rectum and the anal canal and anus. Okay, the sigmoid portion forms the S-shaped loop and ends at the rectum at the level of the third sacral segment. Okay, third sacral segment. That's just something you need to remember, where the sigmoid portion ends. And that's where the rectum begins. Okay, the rectum extends from the sigmoid to the anal canal, and the anal canal terminates at the anus. Okay, you don't need to know all of this stuff, just basic anatomy. Okay, basic. So this is your anal canal, anus, rectum, sigmoid colon. Okay, so barium enema, the clinical indications for a BE can be colitis, specifically ulcerative colitis. Okay, those are bleeding ulcers usually in the colon. Diverticulosis, pouches on the colon. Diverticulitis, which is an infection of one or more of those pouches on the colon. Tumors or neoplasms, it can be colon cancer like these pictures here, or it can be benign tumors. It can be a volvulus, which is a twisting of the large bowel, the colon. And that can, if it's twists and the blood supply is cut off long enough, it can lead to necrosis. Intusception, this usually happens in little ones where the bowel telescopes in on itself. Okay, a barium enema with these kids usually will resolve that. Okay, and then appendicitis is another indication for a barium enema, but I never in all my years have seen anyone order a barium enema for appendicitis, just saying, okay? But it is an indicator. Okay, ulcerative colitis, this is how it can present, okay? Very gnarly looking. This colon should be nice and smooth, nice haustra, and it has just, this ulcers have just wrecked the inside of the lumen of this colon, okay? Very painful and can turn very cancerous. So you got to get that checked out. Okay. This is showing diverticulums here on your large bowel. See all these little pouches. Okay. And the difference between diverticulum and a polyp. Okay. Diverticulum are out pouchings on the bowel, and polyps are growths in the bowel. Okay. Okay, this is your apple core sign. Okay, radiographically. This is showing presence of a little polyp here. Okay. And this is CT imaging. This is the mapping of the colon after the CT has been taken, and certain software go in and map out all of those areas of the lumen for the radiologist. So it portrays 3D imaging, and graphically it portrays all the folds in the colon. Okay, this is a volvulus, and this is a cecal volvulus. So it has twisted on itself. A loop of the intestine twists around, and the mesentery that supports it results in a bowel obstruction. So this can be very painful. They can present bloating. They're of course vomiting because anything that they put in is coming right back up. Constipation, because depending on where the twist is, none of the elimination of waste can occur, or it can have bloody stool if something has been harmed with that twisting action. And you can tell there is something wrong here because this dilated large bowel is huge, okay? And then you have this solid fecal matter here. You have an air fluid level. Okay, so BE procedures. They're allowed to have a light evening meal prior to the exam. Now, if anyone's had a colonoscopy, that is not recommended eating the day before your exam. Matter of fact, you need to have a pretty strict regimen of Jello, broth, so only light non-solids the day before. And then they give you bowel cleansing cathartics, so that's Go Lightly, things like that, laxatives. It's usually NPO after midnight. So there's an 8-hour minimum NPO. We just say no eating the day before, only broths, Jello, any light clear liquids are allowed. There's no gum chewing and no smoking for the same reason the upper GIs don't allow that. That is because it gets the digestive enzymes going, which promotes transportation through the bowel, okay? And usually an enema morning of the exam, that's not something we ever did with patients. That would be something that they might do in-house if there's some chronic issues and they can't cleanse the bowel. Okay, so cathartics, that are substances that get the bowels to empty, okay? They can be irritants and they can be saline. So saline is just going to promote more water to enter into the bowel, which cleanses the bowel and makes you go more with diarrhea. Irritants are rarely used. They do the same thing. They promote water through the bowel. However, it can be very dehydrating, so those are very rarely used. Contraindications to any type of PrEP is gross bleeding from the colon, severe diarrhea where the patient can be put in the hospital just for malnutrition, obstruction of any kind, and any kind of inflammatory lesions like that ulcerative colitis. Okay, large intestine must be completely emptied of all contents. Okay, we don't want any residual fecal matter. It can imitate pathology, as you know. Restricted diet and bowel cleansing regimen is standard, okay? And there's different types of PrEPs for patients that have any of those contraindications for the PrEP. That's something your radiologist has to work out with the referring, okay? There's different types of barium enemas, okay? Single and double. There's closed systems. Okay, and that's what you're going to see is a closed system, okay? So this is just one entry point along this tube. It can exit only in one point, okay? You're going to use cold versus room temperature water. Now that is to prevent cramping. However, they do say that room temp water is fine, just not too warm, okay? The colloidal suspension that comes pre-mixed, you have to make sure you mix it well. If you're mixing your own with your own water, that's where the room temp water would come into play. You need to make sure it's mixed very well before you enter it into the patient. So it's not too thick and it's not too diluted. Okay, these are the commercially prepared things that we can use, okay? The bags come ready to go with the tip, okay? The only thing you have to add on here is the little air compressor device that we add on to blow up the balloon, okay? Okay, we need to make sure that our patient does not have a perforated bowel before we ingest or insert any barium of any kind. This is what can happen if you have a perforation, okay? Barium can enter into the peritoneal space. It can cause massive infectious processes, not good for the patient at all. But this is what that looks like. Okay, air is usually used for our double contrast BEs. Carbon dioxide also may be used. However, that's more rapidly absorbed by the body, so you'd have to work very quickly. Okay, water-soluble agents can be orally administered when retrograde filling is contraindicated. So if there is any type of tumor or bad rectal bleeding, and they can't have a barium enema tip inserted, you can do a BE protocol. You just have to give oral iodinated agents and wait for them to enter the large intestine, okay? Okay, usually we use a soft plastic enema tip. Okay, it has an inflatable air tip on it, okay, to hold it in place. Smaller enema tips are necessary for patients with strictures, fissures, inflamed hemorrhoids, other anal abnormalities. I would never enter a tip into any patient that has any kind of contraindications. That's something that the radiologist needs to do. Okay, retention tips usually have a balloon cuff at the end, and the balloon's inflated with air after it is inserted into the rectum. Okay, these are different types of tips. Okay. Okay, now notice this is for your closed system. This comes just with one tube. This is another type of system, but it's not closed, but it has an air so that you can blow this inflatable retention balloon up. So you've got barium entering through this tube, and this is how you blow the air into this little balloon here. For this tip here, you have a contrast retention tip here. Okay, you've got the air right here for blowing up the balloon, but then you have another air tube here where the radiologist can actually enter the air into the colon for a double contrast. Okay, for safety, the balloon is inflated using fluoro just before the exam. Since techs never use fluoro on a live patient, the radiologist would be doing this, okay? A special tip is required for double contrast. We just looked at that, okay? This is just an apparatus that you would use that you can label if you want. Here's our little bulb that we would have to put on our air portion for the doctor, and then this is our inflated device for the balloon tip, okay? Enema bags have a 3-quart capacity. They're all different, but this one, for instance, has 3,000 ml capacity. Okay, the filter is going to prevent passage of any unmixed lumps of barium. So if you're mixing it yourself, this would be a good bag to have. The tubing is approximately 6 feet long. That's a good thing to have as well. The small bag with the short, large diameter tubing is available for double contrast. Okay, this just shows fluoro setup. The temperature of the suspension should be lower than body temperature. Okay. Anything that's too warm can cause injury to your patient. Higher temps are uncomfortable. Okay, make sure your patient is fully aware of what you will be doing and when. Okay, you need their cooperation. And remember, deep breathing when you insert the tip, deep breathing when you take that tip back out. And if they start cramping, you can breathe them through that, okay? Okay, be aware of your patient's condition, their strength, their age before your procedure, okay? They might not be able to roll over really quickly. You might have to give them extra help. You need to be aware of all of that. Okay, remember what the position is called for inserting a tip into the rectum. Okay, this is the Sims position. They'll be turned on to their left side, usually prone. Roll them to 35 to 40 degrees. Rest them on their right flexed knee and bring that up. Okay, this is the Sims position. What this position does is relaxes the abdominal muscles, decreases abdominal pressure, and it aids in the relaxation of the anal sphincter as long as you're breathing the patient deep, relaxed breathing. That will relax the sphincter enough to enable insertion of the tip. Okay, and this is the Sims position. Okay, your IV pole height can be no higher than 24 inches above the level of the anus, and we use the above the level of the tabletop. Remember that? So no higher than 24 inches above the tabletop. Okay, you're going to run the barium down to the very end of this tip before the radiologist presents. Okay, and if you are doing the tipping, because that's what your site prefers, then you will have had your patient tipped and ready to go first. If you do not do the tipping, you're going to run your barium up to the end of the tip here for your doctor, and you're going to have your patient in the Sims position with just that anal region exposed. You're going to have drapes everywhere else, okay? You'll have lubricant ready for your doctor, and you'll have explained to the patient what the procedure is going to be like, okay? You got to remember to insert the tip very slowly, steadily while they're breathing. You're going to direct the tip anterior 1 to 1.5 inches, and then you change and go slightly superior. You can insert a tip no farther than 4 inches, okay, 4 inches. Once that has been inserted and you blow the balloon on up at the end of that tip, you should feel that catch, okay, and that'll hold it in place as long as you clamp off that balloon tip. Okay, so for a single contrast BE, okay, we're not injecting any air of any kind. It's just going to be barium flowing into the colon, okay? So on request, when your doctor tells you to go ahead and let the barium flow in, you're going to unclamp the barium, okay? And he usually takes pictures, and any spot films will be very few for single contrast barium, as long as you can see the flexures. And look at the pathology here. Looks like that cobblestone appearance here on the bowel. And that can be part of Crohn's disease, which is usually small bowel, but that can also be ulcerative colitis, okay, where the lumen has been affected. Okay, single contrast BEs, they take spots as needed. If you have any overheads, they're usually few, okay? And then when you are finished, you're going to deflate that balloon after you've emptied everything into the bag and let the patient go into the bathroom and clean themselves up, okay? You'll assist the patient to the restroom, okay? After the patient has evacuated, another radiograph will be taken. That's called a post-evac. And you just want to make sure that there's very little barium left in the bowel. If there is a lot of residual barium, you'll go get the radiologist. Okay, so going into double contrast BEs, I don't know if you guys remember, but we talked about a single stage closed system. That's where we use just barium and air through the same system. Or we have a double stage system, the Whelan method, and that's where they go in and they do one type and they let the patient evacuate. Then they tip them again and do the second type of contrast. That is no longer used. And matter of fact, they've redone the Merrill's book. We're now on edition 14 and they've taken this out altogether. Okay, but that is the Whelan method. That's a double stage where there's 2 different stages. Okay, now it was recommended early on for early detection of small lesions, but with the help of CT and MR imaging, they don't need to be doing this anymore. That's the Whelan method. Okay, we use the closed system, which is a single stage system. The patient's only tipped 1 time. Okay, so this is more on those double stages. We're just going to clip over that. Okay, so the barium is introduced and removed via a bag. Okay, the air is introduced either by inverting the bag or that manual bulb from the radiologist. depending on your system that you use, okay? A barium enema series usually consists of an AP or a PA, an AP or PA axial, an LPO and an RPO, or if we're doing PA, an RAO and an LAO, okay? A lateral rectum, right and left lateral decubituses if you've done double contrast, a ventral decubitus if you've done double, and the post-evac film. Okay, so for the AP, this is showing an AP axial. Okay, IR is centered 2 inches above the iliac crest. Okay, everything's midline. Okay, and your angle on your central ray is 30 to 40 degrees cephalad. Okay. You're going to put your central ray 2 inches below the ASIS and at midline, okay? If you're doing posterior PA, you're going to have a caudal angle. And this is going to straighten out that S on your sigmoid colon, okay? Because if you don't have an angle and your tube is perpendicular, when you're taking radiographs, that sigmoid colon, since it's an S shape and it's going from the anus posterior up inferior, it's superimposed. This straightens out that S so that they can see the sides of that sigmoid part of the colon. Okay, so the purpose is elongation of the sigmoid colon. This is an excellent radiograph here. So this patient is prone. So is this cephalad or caudal angle? So remember your angle, 30 to 40 degrees. Okay, so this is a caudal angle if they're prone. Okay, cephalad angle if they are supine. Okay. There's some of the S that's been straightened out. Don't see a lot here though, but there's some of the S right here. That's a good double contrast. Okay, AP is just going to be centered to the midline. The IR is at the iliac crest for all of these. 14 by 17. Central ray is perpendicular, so no angle. So MSP and iliac crest, easy peasy. Okay, make sure your patient is not rotated. Okay, this should demonstrate the entire large intestine. However, everybody's different. So you might be doing 2 crosswise if they're wide. You might need to do 2, 1 up higher to get the splenic flexures. All depends on your patient. Okay, but first one should be centered at the iliac crest, and you'll see how your bowel is situated. Okay, so here is 1 flexure here, your hepatic flexure, then you have your splenic flexure up here. This is your transverse colon, all of this right here. Okay, ascending, descending. Okay, for your obliques. Now you're gonna have a 35 to 45 degree LPO and RPO position. Okay, you're gonna do both obliques depending on how you're doing it, either RAO and LEO or RPO and LPO, okay? We did everybody at 45 degrees, but your part position can be 35 to 45, depending on what you see with your patient when you start taking pictures. Okay, now this is important. You guys are gonna have to remember this. Your LPO is going to demonstrate your right colic flexure and your ascending colon. It also demonstrates your sigmoid. So that is your LPO. So your right side, during your LPO, your right side is elevated. So we are looking at the elevated side, the right colic flexure, the ascending colon. Opposite is true for your RPO. So put yourself in the RPO position. That elevated side is now on the left colic flexure is what we're looking at, and the descending colon, okay? So remember that in the AP oblique position, we are looking at structures on the elevated side, okay? On the elevated side. Your central ray is going to be perpendicular. It is going to enter the patient at the level of the iliac crest, just like before, but now it's going to be 1 to 2 inches lateral from the midline. Okay, do you remember when we did these in class? We did a 45-degree oblique, and then we took their midline and their lateral border, and we split the difference. This should be about right on if you do that same thing. Okay, 2 inches from the midline. So in this patient, she is situated in the RPO. We're going to take her midline, her left lateral border. We're going to split the difference, and her central ray should be about here. So here's her midline. It should be right about there. Okay, and we would be looking at the elevated portion. So her left, her splenic flexure, and her descending colon is what will show up on these radiographs the best. Okay, here's another RPO. It also shows an LAO here. Okay. And we are centering on the elevated side. Okay, and here's some pictures. So for the RPO, we're looking at the left colic flexure, the descending colon. Ideally, the entire large colon should be demonstrated. It's going to depend on your patient, okay? This is a very good image here. Okay, left colic flexure, descending. Here's your sigmoid here. Good picture. Okay, for the LPO, this is also her RAO. Now they're showing a sponge helping her stay up. I don't recommend using sponges when you're doing PA positioning, okay? They show up in your radiographs pretty bad. Now it's different here to help them stay up on the angle that you want them. I don't notice them as bad, but here I notice them quite a bit, okay? So I think it's better just to prop them on their elbow and their knee, their extended knee. So again, it's a 35 to 45 degree oblique. You're going to be centered to the iliac crest, and you're going to be 1 to 2 inches off the midline. Okay, in our lab, we kind of just split the difference. And here is some LPOs. So you're looking at the elevated side. Okay, so the right colic flexure, the ascending, and then your sigmoid. This isn't a great picture of that, but the right colic flexure, your ascending, and hopefully your sigmoid right here is prominent for the radiologist. Okay, then a lateral rectum. So remember, we put our lead blocker for the lateral rectum just like we do for our L-spine spots, okay, and our L-spine laterals. That is to make a better image and get rid of some scatter, okay? So you're going to have them in a true lateral. They can be right or left, whatever the protocol is, okay? You're going to center to the MCP. The IR is going to be centered to your ASIS for your rectum, because you got to remember where your rectum is situated, okay, low in the pelvis. So ASIS and MCP with a lead blocker to absorb the scatter, okay? We're using a 10 by 12 lengthwise for this one. No angle on the central ray, so perpendicular central ray. Okay, remember you need a true lateral. Okay, oh, I don't have a picture of that, darn it. Okay, remember this one is going to have a balloon in the lateral. So in our BE protocol, we have a balloon in this true lateral of the rectum. So we did the ventral of the rectum, ventral decubitus, and we deflated the balloon. Do you remember that? So that was to give the radiologist a different view without the balloon being in the way. Okay, more on that later if I cover that in this one. Okay, so then we did both decubitus. We did a right and a left lateral decubitus, especially with double contrast BEs. Okay, you're going to make sure that your patient is in a good lateral position by checking to make sure that the plane of their hips and the plane of the shoulders are the same. Okay, there we go. It should be centered to the iliac crest, just like before, and at your midline. Now, a thing with your decubitus, we have decubitus sponges for a reason. So if you can get your patient on their bed where your IR bucky is below the level of their lateral border here, so you don't have any cutoff, that is perfect. But if there's no way for you to be doing that, and you're using a stand that has to be under the patient, okay, you're going to have to use a decubitus sponge and get that patient's body up a little higher so that you don't have any cutoff on this side here. Okay, you're going to be used 14 by 17 IRs. And with this slide, we're going to take a break here for a couple of minutes. You guys, it's 11 o'clock. Come back at 11:10. We still have some stuff to go through here. I'm almost done with this PowerPoint, but I want to go through some image analysis with you, and then we'll be done. On a sponge, if you think that would be better, your IR is going to be centered at the iliac crests, okay? No angle, horizontal at the midline. So remember on the midline, though, you're going to have to make sure that you're really, truly midline, okay? Don't go too high, so that you see the light field here. That's not what's important. Is you need to be centered to the midline, okay, for your patient so that it's centered correctly on your IR. Okay. Okay, so on double contrast studies, air or up is the side of interest. Okay, so in the right lateral decubitus, we're laying on the right hand side. We are going to be looking at the medial side of the ascending colon and the lateral side of the descending. So just picture your patient in the right lateral decubitus, and the up side is the side we're looking at. Okay, since they're laying on their right side, and that's on the side of the ascending, we're going to be looking at the medial side of the ascending and the lateral side of the descending. Okay, reverse is true for the left lateral decubitus. Okay. Now here is your lateral rectum that I was telling you that you have. I wanted this picture back with that other slide, that you have a balloon demonstrated in this one, okay? And that we do one later of the rectum that has no balloon, that is blown up, okay? But this shows you your rectosigmoid region, okay? You need to make sure it's a true lateral with no rotation. You got a nice lateral sacrum here in coccyx, so it looks good in lateral, okay? Okay, so your left lateral decubitus, your right side is up, marked up. So they are laying on the left lateral side. This is the pelvis right here, lung fields up here, okay? So since they're on the left side, this is your descending colon, okay? And we are looking at the medial side, the air side of this descending colon, and the lateral side, the air side here of the ascending. Does everybody get that? Okay. All right. So here's your right colic flexure. Here's your air fluid levels, or in this case, air barium levels. Okay. Your rectum, your sigmoid part of your colon. Here's your descending colon full of barium. You got a little bit of air right here. Here's your left colic flexure. Okay, remember to mark your decubitus films with an up arrow, okay, for the radiologist. Okay, now this is your right lateral decubitus, okay. So, oh, this is a nice one. It's got the entire colon demonstrated, okay. So now we're looking, so they're laying on their right side. They're laying on their ascending side. So now we're going to be able to visualize this medial aspect here, okay, of the ascending, and then the lateral aspect here of the descending. Okay, and this is your splenic flexure, your descending, your sigmoid. Okay, and then you've got your ascending. Something's going on here. This is really dilated. Air barium levels. Okay, here's your transverse portion. All righty. Okay, now your ventral decubitus. Okay, this is the one I was talking about earlier. Now this shows a 14 by 17. Okay, we want to get the entire bowel if possible. Okay, your entire large intestine is going to be demonstrated if possible. We don't want any rotation, so make sure they're nice and flat with both arms up by their head. Okay, they can clasp their elbows and rest their head on their arms. Okay, and what we're looking at here is the airfield up portion. Since they're laying on their stomach, these are the posterior aspects of their colon walls. Okay, posterior aspects. Okay, now generally what we do with this one is we're going to deflate the balloon. We don't want the patient to let go of that barium though, but we're going to deflate the balloon. And as long as you have all of that rectum demonstrated, then the radiologist now has two views of that rectum, sigmoid colon area, one with the balloon obscuring some of the area, but one without. Okay. All right, and then our post-evac, we have let the patient evacuate that barium into the bag. We usually put it on the floor and let gravity do its job. Once you notice that there's no more barium going into the bag, you remove that barium enema tip. You escort your patient into the restroom and have them evacuate all of the barium that they can evacuate and get them cleaned up. And then they come back for one more film, and this is a post-evac. This can be done PA or AP, and you're going to center out the iliac crest and make sure you mark post-evac. Okay, for AP oblique projection in the RPO, this is going to demonstrate what? Okay, and the answer is you're going to be demonstrating the elevated portion in the RPO. So elevated portion is going to be your left colic flexure. Okay, to demonstrate the medial side of the ascending colon. The medial side is a hint that I am laying on this side, okay? So I need to be laying on my right side. That's going to demonstrate the medial side of the ascending colon and the lateral side, the upside of the descending colon, okay? So I'm going to need to be in a right lateral decube. Don't forget the decube part, because otherwise it's just a right lateral and everything's superimposed. Okay, and that's the end of that PowerPoint. So let's move on. We're almost done, you guys. Stick with me here. Okay. And I am back. Here I am. Okay. Any questions on any of that, you guys? Any questions at all? Yes.
Teresa, I have a question.
Yes.
So we just went over the right lateral decubitus. So for the left lateral decubitus, so we're visualizing medial aspect of the descending.
Correct.
And lateral aspect of ascending.
That is correct. Yes. Okay. Good. That is correct. That's probably going to be on the board. You're going to see an image and they're going to want to know what position they're in. And you're going to have to look at those air barium levels to let them know what position.
Okay. Thank you.
Just remember your central ray in almost all of your patients, in your ideal patients, is at the iliac crest and the MSP. Okay, for all these barium films, except for your very small ones that are of the rectum, and then you're going to be centering lower on the ASIS because that's where the rectum is. Okay. How are you guys doing?
All right.
Are your brains hurting?
Just overwhelmed.
Yeah.
You guys are learning a lot. You're making a lot of synaptic connections right now. Just keep the faith. The light is at the end of the tunnel. You have 26 more days and then boom, you're going to be eligible to take your board. So study hard now. It'll be totally worth it. Okay. I'm going to let you go, but in Moodle for this week are these 3 slideshows. Feel free to review them if you want. I'm going to post this video as well, but there's also 2 image analysis. And I don't know if you guys remember doing them, but they're both in there and you can review the anatomy on those images. Okay, that would be a good exercise for you guys to do if you have any extra time. Okay, unfortunately, I don't have time to go through them with you. All right, but you guys are doing a great job. We will see you next week. Mark will be with you on Tuesday.